So of course, one major question is how to manage pregnancy, and there was an entire discussion about management of pregnancy, and of course we have to be very careful with disease-modifying treatments and make sure that we stop them at appropriate times prior to trying to conceive, and we discuss some strategies in terms of how to manage women who are likely or who have relapses during pregnancy. That is with using IV steroids safely in the second and third trimester, and also postpartum relapses, and whether to initiate disease-modifying treatment early, use IV steroids, IVIG. Those are all strategies that have been used in studies. As well, higher doses of estriol have been used in women and studied in women, and this has been shown in a trial by Rhonda Voskuil to have some benefit in especially the first year of its use. So in general, I think the risk of relapse after pregnancy may be a concern, but if this is well managed, then it shouldn't prevent pregnancy from occurring, or prevent the thought of becoming pregnant. It is an individual choice, so each woman must decide for herself. But I think now we have more information about how to safely manage a pregnancy and best advise a woman, and we do know that pregnancy itself is protective for MS. So a number of groups have tried to look at whether having pregnancies affects the long-term outcomes of MS, and it is difficult to analyze this data because women who are more disabled tend not to become pregnant for obvious reasons, and so this has to be taken into account when you're designing a study to look at this. Some studies have shown some benefit, others have shown neutral or no benefit, but I think it's difficult at this point to be definitive about that outcome. And that's an unexplored area in MS, but an incredibly important one since women are aging, and we need to best manage their disease through the menopausal transition as well as postmenopausal years. So we had a review given by Dr. Beauvais who works at our center, on the impact of menopause on MS, and there seems to be a trend and a slight increase in the EDSS score, and this again needs further replication, but we must be cognizant and look for any changes in women who are going through menopause. As well, symptoms can seem worse. I think the disease-modifying treatment is probably going to be unchanged, that aspect, but the symptomatic treatments and thinking about treatment both for MS and symptoms that can be exacerbated in menopause, possibly like hot flashes, bladder issues, depression, fatigue, all of those are both important in both situations, and so paying attention to treatments in that period of time is going to be very important. And I think that's why it's so important to understand the overall disease course of MS and what to expect at different phases of life. So in adolescence or pediatric MS, we know that relapses and inflammatory activity is very common. In the 20s, and depending on when a patient has their onset, then relapses can be a main feature, as well as some of the symptomatic issues, possibly fatigue, and also thinking about where a patient is in their life, and maybe they're thinking about planning a family, they have their first job, they're finishing college, etc., and how they can deal with their everyday needs and best manage any symptoms that they're having. And then in the 30s and 40s, again, I think we're trying to ward off disease progression and best manage that. And then through the menopausal transition, as we just talked about.